Welcome to Dental XP's webinar on transcrestal sinus floor elevation, the most frequently asked questions. My name is Michael Toffler. I'm a practicing periodontist in New York City. I'd like to thank Dental XP for making this possible and giving me this opportunity. In particular, I'd like to thank Tyler Binner and Eddie Salama for their technical assistance. Brief disclosure. I have received honoraria from Toman Medical for presentations on their implant system and from Intralock for presentations on platelet-rich fibrin. I periodically receive royalties from H&H Company for osteotomes I've designed. I'll begin my discussion with preoperative CBCT analysis. It is really not just about residual subantral bone height. You shouldn't solely be asking yourself, can I do a transcrestal elevation at 3 to 4 millimeters, or do I need at least 5 millimeters? Please also consider the width of the sinus at the proposed implant apex. And why is this important? That's because membrane detachment force is correlated to the circumference of the elevated area. It's going to take more force to elevate the membrane 4 millimeters in an 18 millimeter wide sinus than it will in a 9 millimeter wide sinus. More force, greater risk of membrane perforation. I'll define a wide sinus as one that is 12 to 13 millimeters in width at the proposed implant apex. The buccal palatal dimension of the sinus should be considered when you are selecting your surgical approach, graft materials, whether or not any are used, whether or not you'd like to include autogenous bone, the healing time, giving more healing time to a wider sinus, as well as the planned height of transcrestal membrane elevation. Increasing sinus width not only increases your risk for transcrestal perf, but it also makes it less likely that you get intrasinus bone coverage, especially on the palatal aspect of your implant. I cannot stress enough the importance of preoperative sinus health if you're going to avoid postoperative complications. I always look at the status of the Schneiderian membrane, average thickness about 1 millimeter. Benign mucosal thickening of 1 millimeter is common, and many studies consider any thickening of less than 2 to be normal. Pathologic thickening has been reported in 23 to 56% of the patients that undergo implant treatment. When is membrane thickening a concern? I am actually less concerned about membrane thickening than I am concerned about the patency of the ostium. A patent ostium reduces your risk for postoperative sinus infection. Now, what is the prevalence of a blocked ostium or sinus obstruction with a flat or semi-aspherical membrane thickening of less than 5 millimeters? Well, it's very low, 7 to 11%. If the thickening is 5 to 10 millimeters, 24 to 36%, greater than 10 millimeters, up to 74%, and if you see your sinus completely occluded, then I would assume that your sinus is obstructed. Post-surgical complications or compromised results tend to be associated with pre-existing sinus disease or documented susceptibility to sinus disease. Unfortunately for us, sinus diseases and abnormalities are prevalent in the patients that we schedule for sinus floor elevation, and their presence may increase your surgical difficulty as well as the risk for postoperative infection. This is why it is so important to know when to refer, delay, minimize, or even avoid sinus floor elevation. So when should you consider a referral to the otorhinolaryngologist or the ENT? Preoperatively, if your patient has a history of sinusitis or sinus findings on the imaging that are unclear or the patient is presently symptomatic. Postoperatively, when the sinus complaints fail to respond to antibiotics or your surgical treatment. In this symptomatic patient with a history of chronic sinusitis, I might not expect the same results treating the right sinus that I achieved with the left, nor would I treat this right sinus until the ENT assessed this patient with an endoscopic exam, as well as a radiologic evaluation of the osteomeatal complex. If I refer to the ENT, he tries to perform a fiber optic nasal endoscopic exam. Here you see a drawing of the right lateral nasal wall. Number 1 is the middle turbinate, which is displaced medially by the Freer elevator. Number 6 will represent the line of resection of the uncinate process that is performed during functional endoscopic sinus surgery. 7 is the middle nasal meatus, which grants the pathway to the ostium to examine the sinus. This particular patient cannot have a full endoscopic exam because there is a large nasal polyp that's capital P, and suppuration, small p, so the middle turbinate cannot be displaced medially. You see a patient such as this, as we often do you refer them to the ENT prior to sinus floor elevation? Well, this is an antral pseudocyst, average 13 to 14 millimeters in height, prevalence 16%, usually self-limiting. And certainly no treatment is necessary if no sinus elevation is going to be performed. Some might argue that these should be removed prior or during sinus augmentation surgery. However, sinus floor elevation in the presence of an antral pseudocyst appears to be safe, using either a lateral or transcrestal approach. What I'm more concerned about is the relative volume of this cyst and how high it's going to be elevated to determine the chance that the ostium would be blocked. Typical protocol for me, here's a 78-year-old male who is asymptomatic. He has no history of sinus disease. There is no apical pathology of number 2 contributing to the membrane thickening, and he has 6 millimeters of subantral bone. I perform a simple transcrestal elevation and place a 10 millimeter long implant with uneventful healing. Odontogenic sinusitis. Endo and periodontal disease is responsible for 5 to 38% of sinus mucosal disease. Here you see periapical lesion of number 2 that has broken through the sinus floor and has certainly contributed to this membrane pathology. The increased bacteria and toxins in apical lesions can infiltrate the sinuses directly or via vascular anastomoses, porous alveolar bone marrow, lymphatic vessels, and this will increase the likelihood of mucosal thickening. Currently, there is lack of evidence to suggest that you can get complete resolution of mucosal thickening after extraction or root canal therapy. And studies have shown that the mucosal thickening may persist for more than 3 months post-op. So I will wait at least 3 to 4 months before I take a new CBCT to evaluate membrane pathology. This particular patient is very fortunate in that the extraction completely resolved periapical membrane pathology at 4 months. But failure to recognize odontogenic sinusitis prior to treatment can have dire consequences. Here's a 28-year-old female who has 6 millimeters of subantral bone and 3 to 5 millimeters of membrane thickening. She had a 4.8 by 10 millimeter implant placed with simple transcrestal elevation, and it appears that the clinician did a very nice job. But if we look closely at the preoperative CBCT, there is membrane pathology associated with an apical lesion on tooth number 2. At 10 days, she has a very severe postoperative sinus infection, complete occlusion of the sinus cavity. This is a sick patient. And if you look closely at the newer scans, you can see that there is a fracture of the distal root and worsening periapical pathology on number 2. This patient is treated with the extraction of number 2, Avalox, for 10 days, and prednisone because the blockage is so severe. She heals uneventfully. Implant number 3 is still in place. Here's a 65-year-old male with a long history of chronic sinus disease due to cocaine abuse. His right and left sinuses are completely occluded. After consultation with the ENT, he advises me that no implants should enter the sinus. So we utilize shorter, wider implants that go just to the sinus floor to avoid complication. And following this treatment, the patient heals uneventfully, does very well. Here's a 68-year-old male with chronic sinus disease. He has numbers 3 and 4 extracted. I use my typical extraction cocktail, which is mineralized freeze-dried bone, calcium sulfate, and platelet-rich fibrin. And I'm fortunate to have 7 millimeters of subantral bone height, but still the patient complains of sinus congestion and there is obvious membrane pathology. Symptomatic sinus pathology, referral to the ENT. And this patient is treated conservatively, antibiotics and a steroid nasal spray. And after 3 months, we see significant resolution of the membrane pathology. But because he does have a documented history of sinus disease, I remain conservative. I elevate only 3 millimeters transcrestally and do not use a particulate, only platelet-rich fibrin, as the particulate may irritate the membrane. Does very well. This patient sat in my chair and told me, I told the implant surgeon that I had a long history of sinus disease and previous sinus surgery, but he said he only needed to bump up the sinus floor 2 to 3 millimeters to place the implant, so I shouldn't worry. He has tried to close the opening 2 times, but it doesn't work. It can't work. You cannot close an oral antral fistula if there is active sinus disease. This patient must be taken to the OR, have functional endoscopic sinus surgery in combination with intraoral closure of the fistula. Recommended reading. Friedland and Metzen published an excellent article in International Journal of Perio and Restorative Dentistry in 2014 to give you the guidelines as to when you should refer to an ENT prior to sinus augmentation. Now, I do use a transcrestal approach as often as I can, but there are circumstances where a lateral approach is safer and a more predictable option. I prefer to use a lateral or visual approach in patients who have 1 to 2 millimeters of subantral bone, where I feel it is very difficult for me to achieve very good primary stability. Also in patients who have less than or equal to 4 millimeters of subantral bone, but with a history of chronic sinus disease, sinus surgery, or sinus pathology. I feel it's very, very important to have optical and instrumental access to the sinus membrane to optimize my healing response, because I firmly believe that these patients will not heal as well if a sinus perforation occurs. And for extra added safety, I will add PRF to line the sinus prior to grafting. I will also make what is called sticky bone with my fibrin glue because it is easier to place the bone graft in the sinus cavity, cover with a PRF membrane and a collagen membrane, and simply place the implant. Is the use of autologous platelet concentrate beneficial in sinus floor elevation? Well, there is literature to show that it is both beneficial and not beneficial, but I have consistently used platelet-rich fibrin in sinus elevation surgery for the last 8 years, and that's because of its slow, sustained release of key growth factors, for its use in membrane repair and protection, and certainly for its maintenance of primary wound closure. For those of you not familiar with platelet-rich fibrin, blood is drawn into 2 to 8 9 ml tubes. In the absence of an anticoagulant, the platelet activation and fibrin polymerization are triggered immediately. The tubes are spun at 2700 RPM for 12 minutes. I get 3 layers, RBCs, a fibrin clot, and platelet pore plasma. The fibrin clot is easily withdrawn from the tube. It is transferred to a dedicated box where I can create these very thin, strong membranes. I can chop up the membranes into fragments, add them to my bone graft, or I can create these very firm plugs. This naturally polymerized fibrin network sustains a slow release of growth factors and matrix glycoproteins for 7 to 14 days. As you see, the plug is transferred to the box, placed on the grid, and the masher is placed over the plugs, and we get these very, very strong, uniform membranes, which are used in every one of my ridge augmentation surgeries. The fibrin clot can be transferred to the cylinder and compressed with the piston, and I get these uniform, round, thick plugs, which are ideal for use in extraction sockets, as well as transcrestal sinus floor elevation. Now, those of you familiar with the literature know that successful sinus augmentation using a lateral approach is possible without particulate grafting. You can rely more on the osteogenic potential of the sinus periosteum and bony walls with simple membrane elevation only, or with the use of autologous platelet concentrate. If you are not going to use a particulate, then simultaneous implant placement is required to keep the membrane elevated to maintain the closed coagulum space for new bone formation. Here is a treatment example of a lateral approach with platelet-rich fibrin only. 2 to 3 millimeters of subantral bone is available. A window is created. The membrane is elevated. The sinus membrane is first lined with platelet-rich fibrin to protect it during the completion of my osteotomy. A 5 by 11 millimeter implant is placed, and the sinus cavity is filled with platelet-rich fibrin. Here you see the CBCTs at 5 to 6 months, where we have bone growth to the apical portion of the implant without a particulate graft. Antibiotic selection in my sinus procedures. I prefer to have the antibiotic at 2 times the therapeutic dose at least an hour prior, or as an alternative, you can begin dosing the day before surgery. I prefer the use of Augmentin, Ceftin, or Zithromax. Postoperative infections, the rate with a lateral window, 4 to 15%, with a transcrestal approach, 1 to 4%. These infections are primarily anaerobes. I will utilize Avalox 400 mg daily or Levaquin 500 mg daily for 10 days. And depending on severity, I'll use a tapered dose of prednisone or a nasal spray. I would tell you, your patients develop infection after your sinus augmentation surgery, hit them fast and hit them hard, or else they can get a very, very serious infection that will require functional endoscopic sinus surgery, visit to the hospital, trip to the OR. Only endoscopic sinus surgery can relieve this particular patient's symptoms after being treated for infection for 4 months. This could have been avoided. If your patient does not respond to your second round of antibiotics, I would tell you to open your surgical site and debride your wound. Let's move now to a transcrestal approach because there is a reduced risk of infection, cost, morbidity, and treatment duration, but it is not without limitations. It can be performed in a staged or simultaneous approach. If I do perform a transcrestal elevation with a staged approach, I use apical core displacement. First reported by Summers in 1995 as future site development. In 2001, Paul Fugazzotto reported on the modified tree fine osteotome technique, and I reported on crestal core elevation. For the crestal core elevation procedure, I will initiate my trephine preparation in reverse at 1250 RPM with a 5 or 6 millimeter trephine, then forward at 850 RPM to within 1 to 2 millimeters of the sinus floor. Now, this is a relatively safe, simple procedure as long as your ridge and sinus floor are flat. Trephine preparation is certainly complicated by convolutions in the alveolar ridge and sinus floor that can lead to underpreparation at points along the core perimeter. And in an effort to more closely then approach the sinus floor, additional trephine preparation can result in severe laceration of the membrane and possible core removal, as you see here, or displacement into the sinus cavity. This is why I developed the core osteotome, which is 1/3 round, 0.5 millimeter thick. It's a number 5 or number 6 core osteotome, which fits around the 5 millimeter or 6 millimeter trephine core preparation. It's used to prepare the apical 1 to 2 millimeters of the core. Much like an osteotome, the instrument is rotated around the core and directly infractures the sinus floor. This simplifies and reduces the force required for core intrusion. Case example, here's a new mother. She has an active career and she wants the least invasive approach. She has 3 to 3.5 millimeters of subantral bone at site number 3. A 5 millimeter diameter core is prepped to a depth of 3 millimeters. The number 5 core osteotome mounted to a depth of 4 millimeters. This infractures the sinus floor along the core perimeter, facilitating core intrusion to a depth of 4 millimeters. So basically, at this point, I have doubled the subantral bone. For 2 to 3 millimeters of additional elevation with apical, I will apically displace a layered graft consisting of 2 PRF plugs, bovine bone mineral, and then a seal with platelet-rich fibrin. I then place a PRF in collagen membrane, simple primary closure, no vertical incisions, controlled core displacement. I have less postoperative swelling and expedited sinus healing with staged implant placement in 4 months. Here you see at 4 months how nicely we have displaced this core and we have nearly 10 millimeters of subantral bone. There's our starting point. And there is no indication that I even elevated a core. My osteotomy is prepared, a 4.8 by 10 millimeter implant is placed, and eventually restored. But crestal core elevation might not be always so predictable. Here is a patient where a bridge on the upper left has failed. Tooth number 15 is extracted. The patient is solely interested in replacing number 14. He has 3 to 4 millimeters of subantral bone. I create a 6 millimeter core, apically displace that core, graft it with platelet-rich fibrin and bovine bone mineral, cover it with a combination of collagen and platelet-rich fibrin membranes. And at 6 months, I have achieved only a very localized but significant sinus floor elevation. So I displaced the core and it stretched the membrane quite a bit without perforation, but really did not give me the lateral distension of the membrane that I ideally would want. But with careful preparation, we can go back in and place a 5 by 11 millimeter tapered implant in this ridge. So, to summarize, stage sinus floor elevation using crestal core elevation requires significantly less flap elevation in graft materials and reduces the postoperative pain and bruising. However, it requires a wide ridge if we're going to have an adequate thickness of facial and palatal bone around the trephined core. And the extent of elevation is usually limited by the height of pre-existing crestal bone, unless the cores are intruded well beyond the level of the original sinus floor, which of course increases the risk for membrane laceration. This is a procedure that I don't use very often now, but used it when I first started out because I was not as comfortable with a lateral approach. I do find it very helpful at single tooth sites where there are adjacent teeth, where membrane elevation is more difficult and risky, elevating off of the adjacent roots, and also in the elderly patient who are looking for a more conservative approach. Let me now give you a brief description of my most frequently performed implant-related procedure, osteotome-mediated sinus floor elevation and simultaneous placement. I will utilize a 2 millimeter twist drill with stop to prepare 1 millimeter shy of the sinus floor. If you are using drills with stops, you must flatten your ridge. I will always get radiographic confirmation of sinus proximity. Ideally, I'd like to be a millimeter or less away from the sinus floor. And while maintaining this working depth, I will widen my osteotomy with drills, not with osteotomes, under preparing 15%. And I always use drill stops for safety as I increase the diameter of my osteotomy. Utilizing this drill system from Hyacinth, this cast kit, I can safely prepare right to the sinus floor. The ideal preparation of the osteotomy then minimizes the percussive force that is required to infracture the sinus floor, enhancing patient comfort and decreasing the risk of benign paroxysmal positional vertigo. Once the final diameter of the osteotomy has been established at ideal working depth, I will insert an osteotome with similar or slightly smaller diameter to directly infracture the sinus floor. Immediately after infracture, and what you might see radiographically is a bowing of the sinus floor. To avoid uncontrolled intrusion and the resulting perforation, I use osteotomes with adjustable stops, setting them at a distance 1 millimeter greater than my measured subantral bone height. If I have 6 millimeters, I will set the stop at 7. If your osteotome goes in just 1 millimeter beyond your sinus floor, it is highly unlikely you will perforate or tear your membrane. Here you see on the right that the floor has been elevated with the intact membrane. Alternatively, if you do not wish to use osteotomes, one can perform a controlled erosion of the sinus floor by slowly intruding membrane-safe drills in 1 millimeter increments. Here you see Hyacinth's cast drill collects bone in its flutes and pushes bone in advance of it to improve its safety as it approximates the sinus membrane. The slow erosion of the sinus floor with these drills can expose the membrane, as you see here. Piezo surgical site prep can also eliminate or reduce percussive forces as well as the risk of membrane perforation. You can utilize diamond-coated tips or carbide tips, which cut much faster, but this is painfully slow. And a great deal of surgical patience is required, something that I don't have. After membrane exposure, I will verify the integrity with the Valsalva maneuver, direct inspection, and blunt probing. I then insert platelet-rich fibrin, or alternatively, you could insert a collagen membrane as membrane insurance to possibly seal a small, unconfirmed tear and protect the membrane during further elevation. Platelet-rich fibrin is apically displaced to working depth, and this initiates my sinus floor elevation and will accelerate the healing. At this point, you can graft the osteotomy with a particulate if you feel that it is truly necessary. Often I get asked, why am I not using a bone-cushioned infracture of the sinus floor as originally reported by Summers in 1994 in his Bousfy procedure? Well, when I started out, I followed Summers' guidelines to the letter. But I had some concerns with a bone-cushioned sinus floor infracture. I lost the tactile and auditory signals of sinus floor proximity. My assistants know exactly where we are relative to the sinus floor by the feel and sound. I will simply hold the osteotome. They do the malady. It takes more percussive force to compress the bone graft than infracture the sinus floor. And if you have inadequately prepared your osteotomy, you must now remove your graft material and prepare your osteotomy 1 millimeter deeper. If you had a perf before you placed the graft, or you perf during the apical displacement of the graft, you know very well where that graft material is going. And the placement of this column of graft material will not alter the tearing forces on your membrane. I anticipate 1 to 2 millimeters of elevation for each 4 to 6 millimeter bone plug displaced to working depth. I graft the osteotomy as needed to achieve the desired elevation of 2 to 5 millimeters. I prefer to use a rounded implant apex as I believe it is kinder to the sinus membrane. Do you need particulate grafts in combination with transcrestal elevation? Well, what would be the possible advantage of a particulate graft with transcrestal elevation? Certainly the creation and maintenance of space for more bone volume to aid in support of the implant. You would anticipate that you would get broader lateral augmentation and possibly avoid membrane slumping. However, the literature is not conclusive on the benefit or maturation of a bone graft at the apical portion of an implant, and it does not reveal that the resorption of the grafted material or loss of graft volume has an influence on implant survival. And I can definitely tell you that not all apical bone grafts placed with transcrestal elevation provide support. This might have looked very good on periapical radiograph, but you could see my apical graft does very little to support this implant. And successful transcrestal elevation using no graft materials would suggest that apical bone formation, according to the principles of GBR, takes place. Simple membrane elevation and a closed coagulum space. And studies that compare transcrestal elevation with or without particulate grafting materials, as well as systematic reviews, have reported no significant differences in terms of implant survival and success rates. And successful transcrestal elevation has been reported with autologous growth factors alone without particulate, whether it's platelet-rich fibrin, PRGF, or concentrated growth factors. So my conclusions relative to the necessity of grafting material in transcrestal elevation: the choice of graft material is not nearly as important as the maintenance of membrane integrity, as successful membrane elevation always results in bone formation. An interposed particulate graft layer will increase your initial elevation height by 0.5 to 2.4 millimeters, although it will potentiate the risk for membrane perforation, especially in thinner areas of the stretched membrane, such as over a sinus septum. The type of graft material or its inclusion does not seem to influence implant success or post-procedural complications when your elevation is confined to 2 to 4 millimeters. Autologous platelet concentrates can introduce an increased element of safety and healing potential with or without a particulate graft. However, I do believe that in wider sinuses or sites with 3 to 4 millimeters of subantral bone, the addition of a particulate material may more effectively gain and maintain apical sinus bone and prevent postoperative slumping. If I do use a graft material, it will always consist of autogenous bone to improve my bone to implant contact and a xenograph to better maintain my augmentation volume. Should you and your patient be concerned about benign paroxysmal positional vertigo? What you're looking at here is a drawing of the inner ear. Number 1 is the cochlea. Number 2 is the canal for the facial nerve. 3, 4, and 5 represent your semicircular canals. Number 5 is the posterior semicircular canal, the one we're most concerned with. The utricle is where the canalus or calcium carbonate crystals are housed. BPPV is a sudden attack of vertigo triggered by head movements or a change in posture. Percussive forces are capable of detaching the calcium carbonate crystals from the utricle to the end of the posterior semicircular canal right here. Now, when the patient sits up at the completion of the procedure, the displaced particles reposition themselves on the ampular crest. That's the widened portion of the canal, and this disturbs the endolymph system, triggering vertigo. The incidence, 1.25 to 3%, and in the majority of these reports, the malady was induced after osteotomes were used to aid in alveolar expansion, which requires more percussive force. That says something about using osteotomes for ridge splitting or for expanding osteotomies, especially in type 1 and type 2 bone. There is an increased susceptibility in the elderly and those with a history of vertigo and degenerative cervical spine disease. Avoid putting the patient in prolonged hyperextended head position, and I'll demonstrate that. Early diagnosis and immediate application of the Epley maneuver is very helpful in avoiding protracted vertigo, and Compazine and Valium are very helpful for patients with prominent symptoms. Warning, if the patient is positioned as you see on the left with the neck in hyperextension during osteotome application, it increases the risk for vertigo. Please have the patient's head up. Place a soft towel with firm pressure on their forehead. Most common question, how have I safely and successfully managed detectable transcrestal perforations? And I underline detectable because you do not see all your perforations. This is the immediate radiograph I never want to see. I don't want to see the graft material trailing off apically into the sinus, heading towards the ostium. Where does it go? Well, the mucociliary movement transports the graft material toward the ostium, and once at the ostium, the pieces that are too large to pass will occlude the ostium, average diameter 1.79 to 2.4 millimeters. My concern is that the ostium would get plugged with the bone graft material. That's why I don't use putties for transcrestal procedures. If there is a perforation and you're utilizing a putty, the chances are greater that that would block the ostium. It's bigger graft. It's a much larger graft. The incidence of transcrestal perforation, a detectable perforation rate of 3.8 to 6.28 has been reported. But please be aware that perforation may occur at all phases, not just during your drilling and graft placement, but also during implant insertion. And perforation can only be accurately assessed during all phases of procedure by intraoperative endoscopy, and the data on endoscopic procedures show perforation rates of no less than 13%. That's more than double of the reported detectable perforation rate. This suggests that the majority of transcrestal perforations go undetected. So if you do perf, do you proceed or come back another day? Well, let's review the literature to develop a perforation protocol. Microlacerations of less than or equal to 2 millimeters during transcrestal elevation are likely to be clinically inconsequential in the short and long-term post-op periods. Yes, I do believe this is true, but in preoperatively healthy sinuses. What about implants that protrude in the sinus? Well, implants that protrude 2 to 3 millimeters in the antrum can show complete regeneration of the membrane and possibly bone over the entire surface. These photographs are from Jung's article in 2006 in dogs. He placed implants 2, 4, and 8 millimeters into the sinus cavity. At 2 millimeters, the membrane and bone grew over the implant, but at 4 millimeters or 8 millimeters, the membrane formed a tight adherence around the neck of the implant, but debris collected on the exposed portions of the implants. Long-term consequence? I'm not sure. New, intentionally perforated using a 2 millimeter twist drill at implant placement, and all 63 implants protruded up to 3 millimeters. He had an elevated rate of nasal bleeding, but only one patient developed sinusitis, and he had a 98.4% success rate at 1 year. Should you be placing a particulate after you perforate and you attempt repair? Well, using endoscopic evaluation, it has been reported that if the tear is very small, the procedure can be continued and the grafting material kept in place by the remaining intact membrane. But Watzek and Fugel astutely pointed out that this would require that some prior elevation of the membrane occurred before the perforation. And once you perforate in a transcrestal approach, no further elevation is possible. Once a perforation has occurred, the addition of graft material will perpetuate a vertical pattern of augmentation at the implant apices and not allow a lateral distension circumferentially to the implant. Jank in 2011 showed that an initial 1.2 millimeter membrane rupture increased in size in 85% of the cases when a Bowsby procedure was then performed. Garbacia, in her cadaver study, reported that as the implant reached the final position, the graft was displaced in an apical or lateral direction, enlarging a previously detected membrane tear. So, my perforation protocol: here I perforate at 6 millimeter depth with a 2 millimeter twist drill. Once I perforate, I will only utilize an implant length that is 2 millimeters longer than the residual subantral bone height. If this does not allow for a 4 to 6.5 millimeter diameter implant, at least 8 millimeters in length, inserted with an ISQ of greater than or equal to 65, I abandon and return in 3 months. No particulate graft is placed, as stability and vascularization may be compromised. At these perforated sites, I only utilize platelet-rich fibrin. Here you see the platelet-rich fibrin is placed into the osteotomy, sealing the perforation. And I place a 5.5 by 9 millimeter implant with an ISQ of 77, 2 to 3 millimeters beyond the sinus floor, using PRF only. At 4 months, and here is the CBCT at 3 years showing that the sinus floor is relocated to the implant apex. Suggested reading on transcrestal membrane elevation and complications. This text by George Watzek and his group is a fabulous, fabulous read. It has more information on transcrestal sinus floor elevation than you will find anywhere. I had the distinct honor of authoring this chapter in Stu Fromm's new text with Paul Rosen. This will be coming out in the fall. And for information on the procedure, the technical aspects of the procedure, please purchase Michael Sonic's and Debbie Wang's text on implant site development. My chapter is on osteotome-mediated sinus floor elevation. At this point, have we overcome the historical limitations of osteotome-mediated sinus floor elevation? Well, we know about reduced success with less than 5 millimeters of subantral bone, and certainly the reported limited degree of sinus floor elevation with this osteotome approach. And recent reports on transcrestal elevation do show an improved success and safety at sites with less than or equal to 4 millimeters of subantral bone. And certainly that's because our implant design and surface treatments have improved, and we know how to prepare or under-prepare these sites by 5 to 15% to improve primary stability. I've been utilizing resonance frequency analysis and taking ISQ measurements to show a temporal improvement of my bone-to-implant interface, or to guarantee that I have maintained my high initial stability. If an implant is placed with an ISQ of less than 65 or insertion torque of less than 25, I prefer to submerge and protect my implant. And what about these innovative sinus floor elevation systems? Have they given us the ability to predictably elevate safely to a higher extent? Well, let's see what works and what doesn't and why. First, I would ask, how much sinus floor elevation is possible using a transcrestal approach? Well, the extent is a function of membrane biomechanics, or the deformation capacity, elasticity of the membrane, as well as the adhesion force between the membrane and underlying bone. I cannot define these factors in every patient. What I can evaluate, though, is sinus anatomy, the width of the sinus, knowing that it will take more force to elevate the membrane, and that if I have an oblique sinus floor, there may be a greater risk for membrane perforation as well, and a limited degree of elevation. Certainly, the more sites you elevate, the higher you can elevate the membrane. And the more experienced you are, the simpler and safer this becomes. Now, why is the degree of osteotome elevation limited? That's because osteotomes or bone debris elevate via a concentrated point pressure. Ideally, we would like a smooth, evenly distributed transfer force for safe, broad elevation of the membrane, hence the discussion of balloon catheters or hydraulic pressure. Now, I was introduced to the minimally invasive antral membrane balloon elevation by Ziv Mazur, who has had amazing success with this procedure. Site numbers 14 and 15 have 3 to 4 millimeters of subantral bone. This is the second case that I performed. 3 by 3 millimeter osteotomies were created. I directly infracture the floor with an osteotome. I introduce platelet-rich fibrin and apically displace it to a depth of 3 millimeters. I now insert my balloon catheter, screw it into position. It extends a millimeter beyond the sinus floor. My balloon will expand at 2.5 atmospheres. When it inflates, the pressure will drop to a half an atmosphere. Here, dye has been injected into the balloon to see that it is open in your sinus. What it does not tell you is if your membrane is intact. The balloon is left in place for 5 minutes and withdrawn. The sinus cavity is filled with graft material, and here I place 3 10-millimeter long implants, which are beautifully restored. I also wanted to see if I could utilize this balloon approach as a staged procedure at sites where there was 1 to 2 millimeters of subantral bone. I create my small osteotomies, insert my balloon, and inflate. And certainly, I could not have achieved this degree of elevation with an osteotome. But the bone is slowly packed through these 3 millimeter osteotomies, and you can't place much compression force on your graft material because you're pressing up against the membrane. And at 6 months, I see a significant amount of bone collapse and poor bone density. However, I am able to place 2 10-millimeter long implants. My results with the Miambi procedure have not been consistent. This patient had 3 to 4 millimeters of subantral bone, again at site numbers 14 and 15. I thought the procedure went very well. My post-op radiograph reveals a contained graft material. But at 3 weeks, I had a very severe sinus infection. The patient brought the implants in their hand, and I lost my entire facial plate of bone. I do enjoy utilizing a balloon or hydrodynamic elevation in small lateral windows, especially at single-tooth sites. Here I use Dentium's DAS bar to create a lateral window in a matter of seconds. I begin the elevation with piezo surgery. I then slowly insert my balloon and inflate it in increments until I have 10 millimeters of inflation. My elevated membrane. I introduce my xenograft, cover my window with platelet-rich fibrin and pericardium, and precise 10 millimeter elevation at my single site. 5 months later, I can do transcrestal elevation, gain an additional 2 millimeters with platelet-rich fibrin, and place a 4 by 11 millimeter Tomin implant, and where we started. What about hydraulic sinus floor elevation? Well, that sounds great because hydraulic pressure in a closed system places equal pressure on all surfaces within the system, thereby eliminating point sources of pressure and gently elevating the Schneiderian membrane equally at all points of attachment. Can a balloon do that? No, because a balloon does not make 100% contact with the membrane. It will create tearing forces similar to that might be induced by an osteotome with point pressure. I have utilized hydraulic sinus floor elevation with screw-retained or manually retained water hydrants. I'll demonstrate. At site number 3, there's 5 millimeters of subantral bone. After I directly infracture the sinus with an osteotome, I confirm membrane integrity. I then introduce an hydraulic lifter, which is manually stabilized, and a total of 1.5 cc's of saline is injected in 0.5 cc increments, where I inject and withdraw. I confirm membrane integrity and at least 5 millimeters of elevation. I then place platelet-rich fibrin and apically displace my bone graft materials. I place a 5 by 10 millimeter implant at site number 3 and a 4/5 by 10 at number 4, and the patient does quite well with this elevation. I'm not sure that I got much more by utilizing a hydraulic lifter than I could have gotten using my traditional osteotome approach. Mectron's sinus physiolift system involves the preparation of your osteotomy with piezosurgical tips, the insertion of a screw-retained water hydrant, and then micrometric injection of water. And while the screw-retained hydrant is in place, I imagine that my water is hydraulically lifting the membrane as drawn. I withdraw, graft, and place my implant, but it appears on this radiograph that I perforated either during graft placement or implant insertion. This 74-year-old female has 2 to 3 millimeters of subantral bone and a narrow sinus at site number 3. She also has a very narrow ridge at site numbers 4 and 5. I utilize piezosurgery and drills to prepare a 4.1 by 3 millimeter osteotomy, exposing an intact membrane at site number 3. Here you see the very narrow ridge anteriorly. I then perform hydraulic sinus floor elevation, or attempt to perform it, with a 4.3 millimeter diameter screw-retained water hydrant. 2 to 3 cc's of saline is micrometrically injected. What I cannot feel with these screw-retained injectors is the resistance of the sinus membrane to the water pressure. When I withdraw my screw-retained hydrant, I have a membrane perforation. What now? I repair it the only way that I know how. I create a lateral window and lay a membrane over my perforation. I then graft my sinus as I would in a traditional lateral approach. Here you see I have inserted 2 cortical bone pins, which I reported on in the compendium in 2014 for lateral ridge augmentation. The pins are covered with mineralized freeze-dried bone, bovine bone mineral, and platelet-rich fibrin and collagen membranes. Here you clearly see my sinus augmentation and the 2 pins in place for lateral ridge augmentation. 6 months later, adequate bone for the placement of 3 10 millimeter long implants, and excellent healing and very ISQ readings in the posterior maxilla. Unfortunately, so far I cannot report safe, simple, reproducible sinus floor elevation using water hydrants and hydraulic pressure. These devices have not made me give up my osteotomes. A better alternative to simple water hydrants may be hydrodynamic sinus floor elevation, which combines hydraulic pressure subjected to piezoelectric cavitation. Ultrasonic energy can induce a cavitational effect in water-containing tissues, which can in turn facilitate tissue separation. What we have is hydraulic pressure that is subject to piezoelectric cavitation. The water comes in waves, so the membrane stretches and then relaxes, and this may be a safer way to elevate the sinus membrane. And this was reported in Angelo Troadon's hydrodynamic ultrasonic cavitational sinus lift. And he's had wonderful results. He and his co-workers have reported great success. I have not utilized these tips because they fit the Acteon unit. What I have utilized are the HPISC tips, the hydrodynamic piezoelectric internal sinus floor elevation. And this was first reported by D.S. San. and there is a 1.6 millimeter carbide tip which cuts faster than a diamond tip that will decorticate the sinus floor. Recently introduced are these 2 millimeter tips with stops at 2, 4, 6, 8, and 10 millimeters and internal irrigation. So not only do they control the depth to which you can insert the tip, but there is water coming out of the tip which pushes the membrane away as you prepare your osteotomy. After preparing and using the 2 millimeter diameter tips, I will introduce the 2.8 millimeter carbide insert to widen my osteotomy, further expose my membrane. The 2.8 millimeter tip is then inserted 1 to 2 millimeters into the sinus, and then hydraulic pressure, ultrasonic energy are applied for 10 to 20 seconds. Let me show you where I have pushed the transcrestal envelope using this hydrodynamic approach. I especially like it for my older patients who are medically compromised. They are not looking for a long, drawn-out, invasive treatment. At site number 12, the patient has 6 millimeters of subantral bone, which can be treated with traditional osteotome sinus floor elevation. At site number 13, though, he only has 3 millimeters of subantral bone. I prepare the osteotomy with the 1.6 and 2.8 carbide piezo tips to expose and elevate my membrane. There, my membranes have been exposed and elevated. I then add platelet-rich fibrin to my osteotomies to apically displace prior to the placement of 4 by 10 millimeter implants. Only platelet-rich fibrin was utilized, no particulate. ISQs are 73 and 63. Low ISQ, I bury the implant. Here you can see the swelling of the sinus membrane that takes place after this approach. And there the apical relocation of the sinus floor, and look at the increase in my ISQ readings in the posterior maxilla. And the patient is restored. Or this 83-year-old male, this patient as well as his physician are anxious to avoid lengthy or very invasive treatment and modification of meds. So what's the best approach for Mr. B with 3 millimeters of subantral bone? Can we expedite his treatment by placing short 6 to 8 millimeter implants in combination with transcrestal elevation, as it may lead to fewer complications than a lateral window approach to place implants 10 to 16 millimeters long? I certainly would like to. So here I use transcrestal sinus floor elevation with piezo surge and osteotomes. I elevate with PRF, autogenous bone, and bovine bone mineral, place 8 millimeter long implants, and here you clearly see the sinus augmentation. His restorations are inserted at 12 weeks, and 3 weeks later, the restorations on the right side, where I placed a 6 millimeter long implant, where I had only 2 to 3 millimeters of subantral bone. Now, these clinical innovations can potentially improve the safety, minimize the trauma, and increase the degree of elevation, as well as broaden the clinical indications for transcrestal elevation. However, in my clinical practice, they have not yet replaced osteotomes or a lateral window osteotomy. And I strongly believe that a proficiency in both lateral and transcrestal approaches to sinus floor elevation is essential to managing the infinite variations of maxillary atrophy and pathology, as well as your intraoperative complications. Thank you.